Good afternoon. Welcome you all to this session on medical legal aspects, etiquettes, and ethics in ophthalmic practice. As an introduction, we as a community, we know that ophthalmology is one subject where we get a lot of medical legal litigations, and it's on the rise, and it happen at various levels. In this session, we try to a basic understanding of medical legal aspects is very important for any practitioner, also about the professional guidelines. So in this session, we try to share you basic knowledge about ophthalmic documentation, consent taking, and about medical legal litigations, some case studies. In addition to the medical legal as case, whatever we are facing, we also as a community, we are facing a lot of physician abuse, assault, hospital attacks, all these things in recent years, which was not common a decade ago. So there must be some reason for that. And if you are willing to do a deeper analysis, we know that all these are secondary to loss of public trust and public respect to doctors in general. So maybe we are losing that human connection with the advancements and technology and many other reasons. So if you want to change this situation, maybe there is something we have to start doing. As doctors, we do ignore the importance of communication, good etiquettes, professionalism, all these things in our practice these days. So, with this thinking, I have introduced two sessions, one on etiquettes to become a good professional, and one on ethics to become a ethical professional. So, with this short introduction, we are starting the session, and the first topic is by Dr. Mahesh on intricacies of consent and documentation.
Good afternoon. I'm sure you are not going to sleep this hour because it is like a nightmare. Whatever we are going to tell you and scare you, all these things are going to be a nightmare. I don't think anybody will sleep. So let us start with the documentation and consent. These are the two pillars or two things that can save you from any litigation. In fact, medical practitioner is liable by criminal, civil, lot of laws, and Medical Council of India, now NMC, has put down regulations which says there are some duties of the doctor to the patient, and one of them is maintenance of medical records. So that is the one of the duties of physician or caregiver. So, and this is it's an essential element in legal system because that is the one that is going to save you. And the serial documentation also helps to helps in research and giving high quality care also. So let us see one case like this was State Consumer Redressal Forum versus Baldev Kishan, endophthalmitis. Okay, so the case went against the doctor just because the vision was not mentioned in the initial records, just because of that thing. So it is just shows the importance of documenting each and every. Another case was there where the doctor argued in the court patient was an alcoholic, and because of that he fell down and had an injury, and but the alcoholism was not recorded in the document, so court will not consider these things. So this is the importance of documentation. So make sure that vision is recorded and all the findings are recorded properly. So there is something called the fact criteria, FACT. The document should be factual, only information that you see, all important information, and in good language. Actually, don't write the code language which only you will understand, because many of them are not approved officially. It should be accurate and precise. It should be complete. Complete means everything, including if the patient is referred to someone, that also has to be noted. If the patient is refusing to take treatment, that also has to be noted. So accurate, complete, and timely. You have to enter the date and time. And in this case, I think electronic medical records has an advantage because we don't have to write time. It is already there when you entered the last time. So that is one advantage where you don't have. And confidentiality is another important aspect of medical records. The data in the medical records belongs to the patient, and you cannot divulge it anywhere without his permission. Remember, never attempt alterations. That means now the situation is bad in the sense everyone is having a very nice smartphone. You make something like a consent. Today somebody was discussing consent. We will fill. Sometimes we will not fill the surgery. We will not fill the doctor, and patient will sign. He will take a photo. When I signed, this was the situation. He has tampered with the. So this mobile phone is a deadly instrument with which anybody can document what they are signing, and later you cannot alter. So that is important. Never make alterations. Who owns the medical records? The caregiver and the hospital owns the medical records, but the data is owned by the patient. So release of medical record. If the patient asks for a medical records or a report, you have to release it within 72 hours, and it is a right of the patient. Within 72 hours means 3 days. So without any charge. So this is also mentioned by Supreme Court of India. So this you have to give a report. That is very important. Up to how many years you have to keep the records is another issue. Usually we have to keep the records up to 5 years. In roughly, there are not strict guidelines. IP, OP, there are some differences. But to remember, at least keep it for 5 years. So that is the take-home message. So electronic medical records have come in the last probably 5-6 years or 6-7 years, and it is very good, in fact, because court accepts it as a normal records. There is enough and more judgments from the court which says that electronic records are okay. Why? Because a forensic examination can easily find out when you have tampered the medical records. It is easy. You cannot do any change after a particular night, 12 o'clock or something like that. So it has reduced cost. It has helped in research, ease in maintaining lifespan of health. Your records will not be eaten by termites. Safety, audit, faster. So everything. EMR is the way to go in future. There is no doubt. Then, as for me, I also feel EMR is better because automatically date and time comes. My dirty handwriting, not even I can read. So, and there are some steps we cannot omit, like diagnosis. After diagnosis only you can sign out after in a EMR. So that is the importance of EMR. Accessibility, very easy. Research, it helps. So EMR is definitely the thing to go. Now, second part of the talk is consent. Medical litigations are mainly due to lack of consent. In fact, one study showed that 50% of medical litigations are due to poor consent taken or communicated with the patient. Patient will say, I was not told, or I didn't read. So everything, most of the cases are due to the bad consent or improperly taken consent. So that is the importance of consent. So consent it's a legal term. Voluntary authorization by patient or a research subject who knows what is going to happen, the sequences, consequences, and what if it is not done, all these things. So informed consent is a legal term, and it is actually something like a constitutional right, but not a constitutional right as such. Article 21 says patient has the legal right of autonomy and self-determination as per the Article 21. He can consent when to treat himself or not to do anything. So it is a right, almost a constitutional right, even though it is mentioned in the Article 21. So consent has been there for the past more than 100 years, and way back this judgment of Justice Benjamin Cardoso is the key word for consent. Every human being of adult years and sound mind has the right to determine what shall be done with his own her own body. And a surgeon who performs an operation without the patient's consent commits an assault. So this is the gist of consent. So there are different types of consent. Implied consent. A patient is coming to you for dilatation. You don't have to get a signed. You tell that this will cause blurring for 3 or 4 hours, and then put the dilating drops. You can't drive back. So that is called implied consent. Examination in slit lamp, implied consent. You just keep this thing, or even for taking applanation tonometry, implied consent. But there is something called expressed consent. It can be oral or written. usually written. Even minor examinations like INC or fluorescein angiography or procedures or any therapeutic procedures, you need a written consent. Written consent should be obtained in all surgical operations and invasive investigative procedures. So informed consent, there are different types. One is called informed consent. In patient's own language about the whole thing, nature of the illness, treatment possibilities, outcome, what he can expect, what are the complications, what are complications if you don't do the thing, everything. In UK, what they give is valid and real consent. It is voluntarily given by a competent patient with minimum adequate level of information. That means too much. If you do cataract surgery, you need not mention sympathetic ophthalmia because that is a very remote possibility. If the complication rate is 1% or less, probably you may or may not put it in the consent. That is UK consent, that which we are also almost similarly following. But in US, it is entirely different story. It is like a booklet. The whole thing will be there. Alternative, risk associated with treatment, with risk associated with no treatment, everything. That is there. One booklet will be there for each. So they will have to read everything and then sign. That is why the legal litigations in US are much more because of this. Situation in India, it is somewhere between UK and US. Indian Contract Act is the basic act which has some gray area in children between 12 and 18 years. But ultimately, above 18 only, you can give a consent. And in India, there is another thing called doctor-patient relationship is governed more by trust. This was the situation many years back. Now it is changing. We are also becoming like UK or US. So this is just for, we are not gods. So that trust element is reducing and now we are all professionals giving treatment. So a doctor can do a procedure without consent in an emergency, like an accident, suturing, or if the when the victim is incapable of understanding the nature of the treatment. This freedom is given by Section 92 of IPC. I am not telling BNC because we are not read BNC now. It is all still we are going on with IPC because we are just learning that. This case, I keep on telling every audience, Samira Kohli versus Prabha Manchanda. The doctor went for a EUA, examination under anesthesia, and found that there was a ovarian tumor or something. He just removed the ovarian tumor and uterus also. Just called the mother who was standing outside and then removed that. When the patient came out, 40-year-old, she knew that her uterus is gone, she can't have a child, then they sued. So this was the classic case of lack of consent in in that case, Supreme Court has given very clear guidelines regarding consent, given by person, expressed written consent before the procedure, given in the presence of two witnesses, preferably not doctor and patient, and freely, voluntarily, directly signed by doctor. Actually, I had 2 years back, I had a questionnaire. Our own doctors, KSOS doctors, 25% of doctors, we don't sign the consent. I don't know who is signing. The reply, I got a reply from around 300 doctors from KSOS. They say 25% don't sign so I don't know. Let God only save them. Blanket consent is something that we should not take. Camp and all. Just write something, one blank, you get signed. When the patient signs, no, he will take a photo. That is enough. So blanket consent has no. There are some conditions where consent is not required, like notifiable disease, immigrants, armed forces, etc., etc. Don't worry about that. These are all things for completion. And video consent is useful. It is accepted by court also, where there is an evidence. Only thing they may take it for a forensic. Where there any tampering is there, they will check it probably. So this is our study I was mentioning. So what is an ideal consent? There are some gray area I told you in minor consents who should sign, but preferably both parents, and if the child is between 12 and 18, you can ask the child also to sign. Content of the consent, I said it should have, yeah, just 2 seconds. It should have all the serious rare complications and all common, not very serious complications. Like if you do cataract surgery, small lens power may remain, or that sort of foreign bodies, small things you may have to mention, which is common. And rare things which are dangerous like endophthalmitis also you have to mention very small percentage. So this is what the concern should have. Like we in retina, we make the patient write this. This patient is currently has given litigation against me. So I have made the patient's bystander write everything, write it signed and with this thing. So already one vigilance inquiry said I have done everything correctly, and in that printed consent is valid only if you write in the below. I have gone through the consent and understood that patient's handwriting or bystander's handwriting, it should be written. So we are, as KSOS President's Initiative, we are trying to bring out a booklet of consent in Malayalam in next 1 year. Dr. Reena and everyone has promised, Ashok and all will has promised probably by next year we will get this thing. Thank you for the kind attention.
Next talk is by Dr. Ashok Nadaraj. He will be talking on medical legal litigations in ophthalmology with examples of case scenarios and discussions based on it.
Yeah. Thank you, Madam, Reena Madam, for this opportunity, and thank you, KSOS. So, the point regarding consent, as Dr. Mahesh was saying, it was a very important aspect because there are many situations where, without the knowledge of the patient, if there is no emergency, if you do something, that is going to land you in big soup, even though you are doing for the benefit of the patient. Now, what I'm going to do here is, give you some real case scenarios, okay? And we'll have some discussion based on this case scenario so that, there is some information you get out of it. So this is a actual case where a 52-year-old gentleman developed sudden loss of vision in the left eye. And he comes to a clinic in India where he is diagnosed to have very low vision and he has got exudative retinal detachment. So he has got vitritis, all signs of inflammation. Angiogram shows a disc leak, and he was diagnosed to have an inflammatory exudative RD, VKH or uveal effusion syndrome or whatever. And other tests were all, uveitis workup were all negative. Patient was started on steroids. So initially the patient responded, but after 2 or 3 weeks, the response was not adequate. For a second opinion, patient was sent to a higher center. And there a possibility of atypical CSR was made and steroids were stopped. And again, patient was on follow-up, PDT was given, lasers was given, but the disease never improved. And finally, even though it was an exudative retinal detachment, patient underwent vitrectomy, endolaser, silicone oil injection, oil was removed, and in that eye, patient recovered 6/12 vision finally. And 6 months after that, the other eye also the same problem happened. So even in the higher center, everybody was in doubt, nobody knew what was happening, and a final diagnosis of uveal effusion syndrome was made. And scleral thinning surgeries, etc., was made. And the other eye, patient did not regain full vision. He got only 6/60 vision. So the whole process lasted for around 6 to 7 years. And after 10 years of the incident, patient now has given a case in the National Commission claiming compensation of 13 crores from the doctors who saw him initially, because he says all this happened because the initial doctors gave him steroids and they are responsible for it. So this is a case scenario. Now, see, when a case like this comes, what are the things that go on in your mind? Now, if you see, we have the Consumer Protection Act of 1986, and now the new act has come, that is in 2019. Now, in the new act of 2019, medical profession has not been explicitly been mentioned. So, Mahesh sir, what do you feel? Like whether the new act encompasses medical negligence, the Consumer Protection Act of 2019, it is not expressly mentioned. Roll out. So that is not you cannot say that just because it is not mentioned, medical profession doesn't come under the act, because you give a service to somebody and you get a compensation. So that contract, whenever it is there, it comes under the Consumer Protection Act. Then there are something like, see, this case was filed 10 years after the cause of action started. Cause of action means the initiating incident which caused the whole damage started. So that is called as the cause of action. So the whole period is like it happened 10 years after that. So can a patient give a case like that? So actually the limitation period for consumer protection case is 2 years. But if the court feels that, the patient did not get an opportunity to file in those, if they can get a valid reason, this can be exempted. So you should not think that After 2 years, nobody can give a case against you. Even after 10 years, you can. And that is the importance of having proper documentation. My sir said at least 5 years you should keep. So suppose this patient is your patient and after 10 years he has given a case. You have destroyed all the documents after 5 years. What will you do? So I think it is better to preserve, at least in electronic form, all the documents for however long you can. Okay. Now, why this case was filed in the National Commission? They could have filed in the District Commission, no, or State Commission. Why? Because it depends on the amount. Okay. If it is less than 50 lakhs in the District Commission, 50 lakhs to 2 crores is the State Commission, and more than 2 crores, you have to file it in the National Commission. And actually, it depends on the amount of money the patient has spent on the treatment. That rule came only now, but initially it was the amount of compensation you were asking. So if the patient can show that he has spent 2 crores, more than 2 crores for the treatment, then he has to file it in the National Commission. Now,
So what is our, probably all of them spend less than 1 lakh, no?
yeah, it should come in the District Commission only.
It cannot actually go to the
Go,
state.
cannot go. It depends on the amount of money you have, not the compensation you are asking.
Yeah.
The amount of money you are spending, that is the thing.
So even state commission, it cannot go directly.
No, after 50 lakhs, State Commission. 50 lakhs to 2 crores is State Commission.
Depending on the expenses of
No,
the patient.
expense
is there
of the
any
patient.
cutoff?
That is what, like, up to 50 lakhs,
Okay.
District Commission.
Okay.
50 lakhs to 2 crores, State Commission. More than 2 crores, National Commission. And appeals will come. See, you go to the State Commission, that is different. Going up and up, that is different. But initially, where you have to file the case initially, that depends on how much money you have spent. I mean, you have to show. Now, see, this patient, as we said, had multiple possibilities. It could be an inflammatory exudative RD, it could be a typical CSR. You have a differential diagnosis. But you cannot treat a differential diagnosis. No, you have to treat a diagnosis. Then only the patient will recover. So, does treating another differential diagnosis amount to medical negligence? What do you feel, Biju sir? Now, this patient had an exudative RD, multiple diagnosis. It could be anything, it could be multiple CSR. I mean, and every possibility you have something to substantiate with also. So, you can only treat a diagnosis, you cannot treat a differential diagnosis. You have to go forward. So, does treating a possible differential diagnosis amount to medical negligence?
No, I don't think so.
Actually, if you have done the proper evaluation and tests and everything, the interpretation can differ from different doctors.
Yes.
So there is even what is that Batra Hospital versus Kusum Sharma.
Yes,
Supreme Court has clearly mentioned that different opinions on the same findings it is just like interpretation of the data of the lawyers.
And if you to put it forward, does error of judgment amount to negligence? Like a patient comes, you have sincerely seen the patient, but in your opinion, you felt at the time it was that, and you have treated. It is not that you have not attended. So that is called as an error of judgment. So do you think error of judgment comes under negligence?
No.
No.
So that is, yeah, correct.
And reasonable skill from the,
Yes.
that is all expected.
Now the point is, patient, the whatever negligence says is reasonable care. That is all. By which is exercised by an ordinary person in that particular position, an ordinary physician of ordinary skill. That is all that is expected. So that is the important thing. So even error of judgment is not negligence. That is the most important point. Then we have certain tests called Bolam's test, Bolito's test, and all that. Now, what it says is whether you have done something, whether it's right or wrong. How will you measure? See, you've done some treatment and it goes to the court. Now the court has to decide whether what you have done is right or wrong. They are not medical professionals, no? How will they know that what you have done is the other party will say it is wrong. You will say you're right. So this is the two tests that we do, that is Bolam's and Bolito's. Bolam test is like, see, suppose a similar person, another doctor in the same situation, if the court feels he also would have done the same thing, then what you've done is correct. Okay. But the problem is the doctor whom you are calling for this expert witness, he is your friend. Whatever you say, he will say, yes, I will also do the same thing. I will also do. That is possible, no? Because you belong to the same profession, you can fudge it. So now the courts are moving into something called as Bolito's test, where it is not only required that a doctor should substantiate, it should be substantiated by documentary evidence like literature or, journal reviews, etc., which can really show that what you have done is right. So hard evidence or documentary evidence or journal evidence plus what you have done is correct, that is called as Bolithos test. Now, the legal thing is moving towards from Bolam's test to Bolithos test. So, if you've done something like this, no, I mean, the doctor should take a medical review, say that, see, the set of 100 cases, there is a review where this treatment is the treatment. So, you can substantiate it. So, that is one thing. Now, how can I prove that I am right? So, in this particular case, you see, the final diagnosis was uveal effusion syndrome. Okay. And nobody knows what the diagnosis is exactly. So, what you can say is treating a differential diagnosis is not a crime. Whatever is possible, you can do. And you should bring out journal review saying that in uveal effusion syndrome or inflammatory exudative RDs, steroid is the treatment of choice. And you have not done anything wrong. Now, another thing is like there is a saying that no, can I take an expert opinion? Now, you can approach the court and say this is a very complicated case. Now, the court cannot, so many people will be saying, let us constitute a medical board of experts from some big hospital and let them decide on the case. The point is, the court will not agree to it on the face of it. If there is a gross wrong, the court will say, let us just examine the case and see how it is. Suppose the case is grossly wrong, like res ipsa liquitor, where you leave a scissors inside the patient's stomach and it is discovered. There is nothing to prove, no? If it is something very obvious, the court, you don't need a medical board. So, getting an expert review or medical board is not a very easy thing. The court has to be convinced that this particular case requires a medical board, and then only you can get a medical board. Then how is the compensation calculated? It depends on, there's a saying in law which says that it is cheaper to maim than to kill. There is one saying in law. Because if you injure the patient, you have to pay for damages. If you kill the patient, it doesn't matter, I mean, don't take it to the face of it. That is the thing. So what happens is if it's a young patient, like an ROP, that is the main thing. And they will calculate how much the person is going to earn if he had been working for so many years. And what was his earning capacity? So if you have a patient who has been earning 10 crores a month and you had some negligence and because of that he is not able to work. So from day 1 to 30 years, they will say 10 crores he is to earn every month. So like that, they will calculate the compensation and you have to pay a huge compensation. So this is a basic thing. Now I'll say just one more small case also, a scenario. So this is a case of cluster endophthalmitis and the patient has gone to court. Now I'll just show you an example how, the lawyers try to twist you. Now how do they get the whole thing to their side even though you have done everything right and endophthalmitis is not in your control. Now they will ask you how many years have you been performing cataract surgery. If you say 1 year, they'll say you are inexperienced. Okay. And second thing is, have you had similar complications? You would have had endo no before also. No, I'm just telling you, it is possible, no. Now if you say I've had endo, then you say, "Ee doctor serum parivadiyanu ellavarkum endoonu." You understand what I mean? Okay. Then they will ask you, did you perform cataract surgery because you thought it was absolutely necessary? Now the patient has 6/12 vision improving to 6/6. Now can you say it was absolutely necessary to perform cataract surgery? I'm just telling you. Then another thing they will tell you is what is cataract? Then you will say lens will become thick, hard like that. Okay. Then they will tell you, do you know the normal thickness of the lens? And you don't know, no, it is 2 millimeter, 3 millimeter, because it's all theory, it is not at all relevant. Then the lawyer will say, you don't know even the thickness of the lens. Then how can you diagnose cataract? I mean, that is a very useless question, but the judge will think that, you see, this doctor has absolutely no knowledge. To one doctor, they even ask how many bones are there in the body, suddenly. So the ophthalmologist doesn't know how many bones are there in the body, no? So he said, I don't know. See, this doctor doesn't even know how many bones are there in the body. And this doctor is operating on the patient. So these are, and they will talk about protocols, like, did you put povidone iodine in the eye? Then they said, did you promise that after surgery you can go driving home? Like that. Yes, and you drove. When you drive home, dust will go inside the eye, Now because of that, did you advise patch after surgery? No, I didn't advise because normal cat doesn't need a patch. So you know what will happen if you don't put a patch? Dust can. If dust goes in, can they have infection? Yes, you didn't put a patch, that is why this has happened. So, see, all these things, will come, the obvious things which you cannot even explain, these things will all rise up and these are all questions which you cannot answer. So the whole take-home message is loose talk by medical professionals is the main cause of litigation. So at least in our profession, if you look at lawyers, if one lawyer has a problem, everybody will jump into it and corner that fellow who's giving a case and they'll finish him off. So in these things also, at least medical professionals should stand united for good things. I'm not saying that if a doctor is negligent, totally negligent, you should support him, but at least you should be reasonable and you should not backbite another doctor. Then especially doctors who are relatives of the patient, who try to show them that, they will reveal everything to their relative and say that this is what has happened, etc., etc. And follow established protocols, document everything, take proper consent, video consent if necessary. And once you get a case, it is very important that the lawyer doesn't know anything. It is your case. You have to go behind the lawyer. You have to run your own case. And it's not like a doctor where you have the full responsibility of the patient. Lawyers have no responsibility towards you. And only 2 minutes before the case, they will look at your paper only. You will feel that they have been looking at your paper for all the time. They are reading your case only. It is not like that. And always be a part of professional protection schemes so that you're protected. Thank you.
Thank you, Dr. Ashok, for giving all those tips and with examples. I think it was a very good revelation of how and where and when you can go wrong and how you can protect yourself. The next topic is it's my innovation actually. I thought we need to improve on our professionalism. As doctors, we are always focusing on our science and skills, and we are ignoring, maybe to a great extent, the importance of all those things which improve our human connection. So in curriculum, our young doctors are not getting an opportunity to learn these kind of things which will improve them as a professional. So over to Dr. Biju John to talk on this topic.
Thank you, Reena, for this opportunity. So this is a bit gray area, not like what Dr. Mahesh and Dr. Nataraj has probably told you about what is within the purview of law. So this is probably something a bit outside that. I don't think anybody is going to sue you because you don't, go for this proper etiquette. But sometimes it can actually sort of prevent the patient from suing you. You can influence the patient's thinking. So etiquette, maybe it's a customary code of polite behavior in society or among members of a particular profession or group. As I said, no binding laws, cannot be enforced. But then when you look at some of these incidents that you see around you, especially among your younger colleagues and all, you really wish that there are some laws regarding this professional etiquette and there is some way by which it could be enforced. So I will just take you through a few examples from my own experience and try to impress you regarding things. Some of these common contentious issues that we often get into a fight with your younger people and the PGs, and we try to sometimes need to scold them, is about the references. Now, we all know this joke that has been carried over the years regarding a misleading reference. I think you all know this one, no? A reference to a urologist. Patient age, not able to pass urine since one day, please come and pass urine. This everybody knows. But this is one thing which when I was doing residency, I was doing my house surgency in medicine in Kottayam Medical College, I experienced. The reference was from urology to medicine actually. This was the reference. Referring this patient with BO, ST and DM for evaluation and fitness for TURP. Now, I just finished my posting in urology and I'm medicine. So the medicine professor is looking at me and asking me, what is BO? Because you just finished urology and have come here, no? So what is BO? I didn't know. So he gave me a punishment. You just go and go to urology department, find out what is BO and come back. There was no mobile phone at that time. So I had to actually go to that area. And it was very difficult facing the HOD of urology, who was well known for his temper. So I just managed to ask one of my, one of the postgraduate students there, Cheta, what is this BO? And he's looking at me as if I'm an alien from Mars. You've finished 2 weeks of posting in urology, you don't know BO? So BO, it just means bladder outlet obstruction. It's a very simple thing for them, but not very simple for somebody who is outside the specialty. Now this thing happened in our specialty also. We often refer patients like this. Patient with AMD needs IV Lucentis. So it goes to medicine people. He doesn't know what is AMD. And IV, he thinks it is intravenous. Okay. So we need to actually avoid short forms when we are actually writing these references, especially to other specialties. And even from our own department from another subspecialty. Now I got a reference regarding some patient with a DRS, evaluate the fundus with a DRS. I thought DRS to me is diabetic retinopathy studies. Actually, it was Devine Filtration syndrome. So, in this reference, I think we should avoid the short forms. And IV Lucentis, you need to specify what is actually expected. You are not asking a fitness for the procedure actually. You are asking fitness for that medicine. So, this need to be actually sort of stressed in the particular reference so that proper reply is obtained. Now, a consultation to ophthalmology. So this often happens. They have this posting in our department. We just train in our various specialties. They had a good glaucoma screening. It was during that glaucoma week walk. They actually participated in the glaucoma walk also. They know everything about glaucoma. We even taught them how to actually look up the fundus. So we get a reference like this. Patient admitted in ward with fever and chills is having a large cupping in fundus. Kindly come over and see. So it comes to our busy OPD. So as you know, it's a highly irritated ophthalmologist got irritated and gave back a reply like this. Can anybody read that? So this is sometimes what happens, like Mahesh was telling. So I was actually sort of trying to write this with left hand. When my wife asked, what am I doing? I'm trying to make the handwriting a little worse. She said that no need for you just write in your normal hand. It is bad enough. So this is that. So what is means is no emergency intervention needed. Kindly send the patient to the OPD when ambulant. So that is what he meant. Now because of the readability, what happened is that 1 hour later, the patient is sent to the ophthalmology casualty in an ambulance. So even if you have a bad handwriting, please, you can make it a little more legible by making a little more effort. And if that is not possible, you can just use capital letters. So this is very important. Now, another reference. Consult a neurologist. Patient is admitted with history of defective vision and pain in one eye, 1 week, on exam there was circumcondylar congestion, posterior sinus K. Similar episode 6 months back, fundus examination showed X-ray retinal detachment. On admission, his BP was all these things. What is this? Reference or essay? Do you think somebody sitting in the medicine OP is going to read through all these things and actually find out what exactly is happening? So he is going to get a reply like this. Thanks for reference. Case in 2 minutes. No intervention required. So first 2 or 3 sentences itself, you should be able to convey what exactly you want. So probably this patient, you should write a reference like, say, this is a patient admitted with a Watt-Koinagi-Harada syndrome. We are suspecting this thing. Kindly evaluate for any neurological problem. So the idea is immediately conveyed and you get a proper evaluation. So this was another, some usual reference that I get. Patient has an intraoperative nucleus drop during cataract surgery. He is being referred for emergency vitrectomy. Emergency? Are you kidding me? So what is emergency? Emergency was there. Now I think you have got a time of at least 1 week or 2 weeks. Now the patient comes in an agitated state thinking that he is going to be taken straight away to theatre and operated then and there. And he picks up a fight with us also. So this should be avoided. You should actually tell them that no emergency, you can go. The doctor will evaluate and probably fix a date for the surgery like that. Whatever is needed will be done, but that freedom should be given to the particular VIA surgeon or doctor who is actually treating that and not unduly stressing him. Again, unnecessary comments and belittling a colleague, that should be avoided. For example, this happened to me. A 70-year-old man with long-standing hypertension, CABG 2 years back on anticoagulants, is present with a submacular bleed. And could actually do an OCT and Octa. We could just make out that the CNVM network. So hemorrhagic, there was some SRF also. Poor risk for other investigation. So we explained everything to him. We took a consent. We took a fitness from the cardiologist, physician, took a detailed consent and gave an intravitreal injection. So after 2 injections, the patient casually said that he had some unsteadiness of gait. So that was there previously also, but that was when it was reported. We actually asked for a neuro consult. MRI was not in our hospital. He was referred to a higher center. There an MRI was done. So it picked up the subretinal bleed, and report it was written that as a mass-like lesion probably bled in the vitreous cavity abutting the retina. So he came back to the neurologist. There one SR. He just casually marked that see, because of the injection, you have got a bleeding in your eye. So you just go immediately require some treatment. So, I mean, you can guess what happens next. The patient thinks that it is because of the injection that it has actually happened. But it was actually for that same problem that we gave the injection. So this sort of comments should be actually avoided. Now we also actually sometimes, inadvertently pass on these comments, which are especially seen in these situations, patients coming with post-cataract surgery complications in some other place, missed findings, especially trauma, missed foreign body, something like that. So some young doctor might casually remark that this is there, that was not found out in that place. Referred corneal ulcer glaucoma, which is seemingly mismanaged, could be due to the sort of situations or the scenario that is there. So avoid comments like that and passing the blame. Trivialization of procedure is another thing that we should not do. For example, patients referred for the intravitreal injection often comes to you, tell, sir, I was told to come here and get an injection to suck out some fluid. I've taken half-day leave today, hope I can rejoin office today afternoon. So this injection, the intravitreal injection is so trivialized, they just take it as some other injection itself. So again, a proper explanation should be given and reference should also be written in a proper manner. They should understand what is happening. Cataract counseling by PRS is another contentious issue because PRS doesn't know the difference between an immature cataract and a mature cataract. And often, we get a lot of patients coming for second opinion. You must have seen many complaints in the social media also because of these things and all. But cataract sometimes, because I remember that when I was after my postgraduate examination, I actually worked in a mission hospital which was doing a lot of cam surgery at that time. And that was in a remote area in Tamil Nadu. And we used to have great difficulty in actually getting patients to obey us and come with us for the cataract surgery. But we had this brilliant PRO, he would, most of those are mature cataracts. So I just listened to them, the way he was explaining. So he would just say that, you have got, the കണ്ണിൽ നിന്ന് പുറ ഇരിക്കുക പുറ മുറ്റിയിരിക്കുക ഇത് കൊഞ്ച നാൾക്കപ്പുറം இந்த പുറ വെടിച്ചിടും ബോംബ് വെടിക്കുന്ന മാതിരി വെടിച്ചിടും അപ്പുറം இந்த பார்வை ഞരമ്പ് കട്ടാവും അത് മട്ടുമല്ല ഇത് രണ്ട് കണ്ണും കൂടെ ഒരേ ഒരു പാർവ ഞരമ്പ് ഇരിക്കുക ഒരു കണ്ണ് പോയച്ചാൽ രണ്ടും നെക്സ്റ്റ് മൊമെൻറ്റ് ദ പേഷ്യൻ്റ് ഈസ് ഇൻസൈഡ് ദി വാൻ and this sort of probably maybe I used to enjoy it at that day, but now thinking back it was not actually something which I feel very proud of. Maybe for some we need some sort of an explanation for mature cataracts in order to make the patient come for the cataract surgery. But when this sort of counseling is also used for an immature cataract and this patient goes for a second opinion, then you get into trouble. So how you explain these things, you can actually tell them, you have got a cataract, so it's better maybe at this stage you can undergo a phacoemulsification, it will be easier. So things like that can be done. So you need to be careful. Now, a doctor in the OPD or ward should not only act like one, but should look like one also. I'm afraid to actually talk to students, about this to students now, but some of the situation, we have got a house surgeon who has got a hair like an Amazon rainforest and his shirt looks like as if it has never seen an iron box, and is wearing a gravity-defying jeans. So these sort of people, I could actually go to him and talk to him and change, influence him so that he is changing his attire, and the problem was solved. But then I would never go to. There was I think I remember seeing a female JR, doing a direct ophthalmoscopy with a luxurious hair actually doing what is known as like a windshield wiper on the patient's face. So that sort of situation, I won't probably interfere, but decency and decorum must be maintained in your attire and appearance. That is very, very important. And you need to be courteous to your patient, you need to show empathy. So all these things are very, very important. And some of these situations which we often forget, reducing the illumination slit lamp and actually switching it off after examining a patient. Indirect ophthalmoscopy beginning in a low illumination, explaining to the patient about brightness and gradually increasing all things. Returning to IPC to zero dioptric position if you have made dioptric adjustment is something which you often forget and tend to put the person who is actually coming after you in trouble. Then writing a proper diagnosis, which is sometimes often very difficult to actually tell to the postgraduate students because they seems to have thinking that all these findings constitute diagnosis. Findings are different, diagnosis is different. So you need to always write a proper diagnosis and management plan and management plan, putting your signature and seal at the end. Never forget. And I will also end with one of the clinics. We have got a palliative clinic in our college where we can see that there is one chair which looks like almost like a simhasanam, a very big chair, and the others are all small chairs. So I thought that chair must be for the chief doctor, unit chief. No, he said that chair is for the patient. These are the chairs for us. As far as we are concerned, the patient is our guest. So the guest should get the most important chair. And they tell us that the patient should always be treated like a guest. So just sharing that thought also. Thank you.
Thank you, Binu. Fantastic talk, all from experience, not from textbooks. Like Mohan sir was once telling, if you have a conjunctivitis patient, you go and open the door for him to get out so that he doesn't touch everywhere and contaminate. That also tells you the etiquette and thing. So after the next talk, we will have some discussion. So Dr. Reena, chief instructor, is going to talk to you about another of textbook topic, art of ethical decision making in complex clinical situations.
Thank you, Dr. Mahesh. Decision making is an art by itself, and like any other art, it has to be practiced to be perfect. So, what do you mean by ethics in medicine? And it's actually an inherent and inseparable part of medicine because we are supposed to be healers, no? So, then it has to be done in an ethical way. So when ethics in general or it's a philosophy based on moral foundations. But when these values and morals are added to human activity or any life sciences, it is called bioethics. There are so many sub categories. You may be familiar with research ethics and medical ethics. But what we are concerned today is about clinical ethics, which will help you in reaching a decision when we are facing with a difficult clinical situation where there are more than one answers. Now we know that there is an interplay between ethics, medicine and law whenever you deal with it. But there are many areas where law is silent. You don't know, there are no proper guidelines or law is not giving you a clear direction what to do. So these gray areas, whenever you are facing with, ethics forms the basis of next decision making. So in practice, any good clinical decision making is based on your scientific knowledge and your ethical reflection. Scientific knowledge, we usually rely on evidence-based medicine. What do you mean by a complex decision making situation? So whenever whatever you are choosing, it goes beyond a therapeutic intervention or a treatment. More than that, you are considering so many other factors also. Then that situation is a complex decision making situation. And these are the situations where ethics plays a very big important role. And why this is important? Because most of the time the patients finally will tell you, doctor parayana pole madi. So doctors will be forced to take these kind of decisions whenever things are a little bit complex. And in most of those occasions, whatever legally or scientifically correct need not be morally acceptable to the patient or to the doctor. So there are some gray situations. So based on your medical knowledge and ethical considerations, you take the decision, but in a complex situation, you have to give all importance to patient preferences. What your patient wants, that is more important. And most of the time, we as doctors, we rely on our medical information to take a decision. But there are situations where you will think, did I do the right thing in this? When it happens is most of the time, when you result in a complication, you made a wrong decision or something went wrong, or when whatever you're offering is not a curative one. So if there are many options in treatment choices, then also this similar situation comes. So in such complex situations, is there any guideline or a flowchart based on which you can take these kind of decisions? So these basic pillars of medical ethics remains the same. So this has to be there in any decision making. So doing good, we all know that it is the most important thing, and doing no harm is more than the important, and respecting patients' choice or autonomy is the third important factor. And it has to be having a distributive justice, that you have to do that same to all patients. Now, when you're faced with a given situation, you have to ask these questions. what is possible in this particular situation? What is the appropriate thing to do? What is permitted by our guidelines and whatever is available? What is the risk benefit ratio? And what is commonly practiced among our peers? So, these questions, if you get some kind of an answer, that will help you reach a conclusion. Now, we may think that are we facing such complex situations in ophthalmology, like in maybe we are not dealing with end of life decisions or maybe cloning and all those reproductive medicine complexities and all. But in general, everyday practice, there are so many situations where you knowingly or unknowingly use ethics. So, whenever you decide which eye to be operated first, when there is an associated complication, ethics is playing a role. A patient who is having an advanced field loss, he says he's a driver by occupation or he's driving a car, will you give an advice? So that also considers ethics. But when if he says that he's driver of a school bus, then again it becomes a little bit more complex. So then always there will be situations where you will be encountering privacy and confidentiality issues also. Now, as an example, this is something which I faced once. This situation there was a mentally unstable young lady. The family wanted her to become pregnant. They stopped the antipsychotics. She became aggressive, self-mutilating, and at that time she presented with a totally injured cornea with total UVL exposure and very, very aggressive behavior. 16 weeks pregnant. What will you advise? Do you advise medical termination and do a surgical intervention, which is scientifically the correct thing to do? Or is it, according to their wish, you will let them continue the pregnancy with a conservative management with the risk of bleeding at any time? Another situation, this is in a medical board. The young girl, 17-year-old, she's having a disability certificate with more than 40% disability, pathological myopia, nystagmus, head position, very poor vision, 3 by 60, 2 by 60, something like that. But she has qualified for undergrad medical admission. So you are in a medical board to decide whether this girl is fit to go for the medical course. So what will you advise in such situations? So there are no hard and fast rules what you should do or what you shouldn't do, and you know that there are more than one answers, and you have to consider the patient factors, what is relevant to that particular situation. And the most important thing is that you may be having a lot of biases and conflicts within you. You may think that I was an undergraduate student and I was normal or normally abled. I found it difficult. So what about this girl who is having a 40% disability? So those kind of biases and conflicts should not be there. So in bioethics, there are a lot of ethical frameworks which are available as flowcharts and other things. But the important point here is that whatever available guidelines and SOPs are there in regarding that situation in your science, that takes a back seat. And what is considered more is about the ethical values in such situations. So these are some of the examples of decision-making models. Always you consider the facts and the stakeholders, you discuss, negotiate, and then finally among the whatever choices you get, you pick the optimal choice for that particular situation. And an important point, whatever you consider, that should have a moral reasoning which you will be able to explain. And whatever decision you are taking, it should be within the policy guidelines and governing laws what is available in the city, because you cannot do something which is totally away from that whatever medical directions are. So you have to find the most acceptable one, but with a moral reasoning. Now, just to that we all are aware that ethics has been introduced as a subject in medical curriculum for undergraduate teaching. Why this kind of a decision by the medical council all of a sudden? It's only because they also felt the importance of having an ethical thinking in the medical graduate. It's basically because of the loss of trust, and trust is the most important factor that helps a patient care and doctor relationship. And the younger generation or the older generation also, they many times we all focus on the skills and the learning and all those higher qualifications, but we give no importance to the professional aspects of in building up an empathetic relationship. So all those things, the good communication, all those things are often ignored because where they are equally or sometimes more important in many of these situations. So all these together, the NMC has also thought that ethics has to be introduced into the curriculum, and now it's a subject, and we are all supposed to teach students, undergraduates, on ethical aspects of different situations. Disclosure of a medical error, you made a mistake, how will you tell the patient? Nobody is teaching us. So what is the goal? So they are trying to give to give students an idea about ethical dimensions in a patient care situation, and also they should have familiarity with the all ethical pillars, whatever I have been explaining. And these core ethical competency they have to develop, and whenever they are exposed to a situation where there is a complexity, they should be able to take a ethically acceptable decision. And then finally a medical graduate will Indian medical graduate will become an ethical professional. That is the ultimate goal with all these characteristics. But what is the irony here? The irony here is those who are supposed to teach, they never got any exposure to ethics in their curriculum, their academics, or maybe they are not even practicing it there in their practice. So how far these things will make a change, I'm not very sure about. So to summarize, it is you always have to follow the ethical principles, which is doing no harm as the most important thing, and you should understand that there are no right answers for a given complex situation, but you have to choose the best for the patient at that particular moment for that particular patient, with a moral reasoning and a proper clinical judgment. That is all that is possible. So find your balance. Thank you. Now, I'll switch in.
Thank you, Dr. Reena. Very important topic like ethics. You have to think that you are in the place of the patient, or somebody is in the place of the patient. What should have been the ideal treatment? In that way, you can decide. This we come across every day. I was just telling in diabetic retinopathy, especially one-eyed patients, the theory is always there. Can just one more, yeah. So theory. Suppose I was just telling about a case. One eye already gone, PDR, NVG. Other eye there is a tractional detachment to the arcade. It's a and the patient is having 6/18. In fact, the patient is coming to me for the past 6-7 years. Regular checkup, vision is sick. So somebody else has daughter has taken her to somebody else. I said tractional detachment threatening the macula. You have to operate. So operate means that put oil inside and become 2/60. So this is not ethics. Actually, the doctor is correct theoretically. So this way, you have to think about the pros and cons, how the patient is going to benefit, whether it will prevent deterioration, like that. So individual, each and every case you have to think like this, and then only take a decision. Especially complex diseases, in our specialty, it is there in plenty. So the younger generation probably they know theory well. So TRD involving macula is an indication for surgery. So that is a problem. But unfortunately, suppose you do that, what will happen to the patient? They should think about the patient's future also. One eye already gone. So that is, just want to highlight that point. Over to you, Dr. Reena, for the remarks.
Is there any other questions or discussions?
Dr. Ashok, I'm a newly new HOD, so I'd like to ask you a question. It's okay to control our own this thing. You do your things perfectly. Suppose a junior does something wrong. Are you responsible for it? How much responsibility with the trained person?
No, actually, if you're heading the department or whatever, there is something called as vicarious liability. A master servant or whatever. Suppose you're working in a hospital. There's a chairman. He's not doing any work. Now you have made some mistake. The chairman is also held vicariously liable. Why they are doing is because you are just an employee. Maybe you will not be able to give so much compensation. The chairman may have more money, and that is why the law is set like that. So there is something called vicarious liability where you will also be held liable.
That is
Yes.
the problem. You can't just go and look
No,
at
cannot.
each and every
No,
junior
that
doing
you
right
have
or wrong. How are you going to end? You end up
Ah,
getting.
so you will end up getting a lot of litigations by the time you retire.
By the time it's time to pay the whole thing. That's terrible.
But Sudha, actually,
Krishna Kumar versus State of Tamil
Yes,
Nadu,
yes, yes.
that pediatrician,
Yeah, yeah.
the
HOD
department, actually the from the chief secretary, I mean DMO or
HOD,
something, HOD,
everybody is
then the
held liable.
last the duty doctor, all of them shared the 2 crores.
Yeah,
All
yeah,
of
that's
them.
what that's what.
So,
So
but
vicarious liability
there is
is
a,
like
there
you
is a
cannot-
guidance for a general guideline. If the person who is in charge is professionally capable of doing that, that person has the responsibility. So if your residents are doing, HOD has to be,
Okay,
or unit
agreed.
chief has to be.
Residents, I agree, but a colleague.
But if the other
is
person is
equally
qualified for that
probably
particular
better
post,
qualified.
it changes. The resident
And
also, the
point
HOD
is,
is
responsible. See,
so that
a
has to be
patient
supervised.
who has had this injury, he has a right to give case against anybody. He can include anybody in that whole thing.
And usually it includes the person's name, who was.
No, the point is, it will be advised by the lawyer whom to include. Patient doesn't know anybody. The lawyer feels that including so many people is going to see. Suppose there is a patient with end off. The retina surgeon will also be involved because the lawyer wants to get more people into it, so there is a chance of getting better compensation.
The HOD is nowhere in the picture, in fact, in that. The
No,
person
that me and
who's-
you know, madam, but lawyer doesn't know.
The point is that there is a senior professor in the theater who was commanding the, or who was looking after the surgery, right? So that person should.
well, the Reena പറഞ്ഞത് important point. If the junior house surgeon or somebody is there, Sudha will be completely liable. But if suppose her associate professor or other professor is there, her liability is only naam ke vaste. Yeah, so that is the thing.
I was speaking to a doctor in the UK, and he's saying at least in a week they get 2 complaints like this. At least in a week, they are trained to take care of those complaints. He's saying there are specific people to take care of it. Initially, they'll do an investigation. Things are all right. They go talk to the patient. So we are not used to it, and I think a curriculum has to be made during MBBS times to
Yes,
take care of
that is
it.
what is happening. And soon we will also reach that stage.
No, if few people go and talk and things get settled, it is okay. But that will not happen.
How to talk also is important, right? Yeah. So that is also very
No,
important.
when the patient is determined to give a case, like they will. I mean, whether it's successful or not, that's a different.
ഇവിടെ മാഡത്തിന് ഒരു ചോദ്യം you can take over
I thought somebody will ask me. Actually, that സമയമുണ്ടോ? Actually, their parents were not willing to terminate at all, which I didn't suggest. I just asked them, and it was continued as a conservative treatment with explaining all the risk about bleeding at any time and emergency intervention, all those things. And that patient was referred from actually Kollam district hospital. I don't know anybody is here. So then they went back, and maybe 4 or 5 months later, I got a call from the gynecologist that she's into labor. Can we proceed with normal labor or those? I said, no, it is an indication for LSES by all means. And after 2 or 3 months, I saw this lady happy, normal, and having a baby, and their whole family with a kind of an adrenoleucoma, pseudocornea, and it's not prolapsing anyway. So that ended up in a LSES, but they conservative management is what opted. And the second one, that was very difficult whether to join the undergraduate course or MBBS course or not for that girl with. Because that was very difficult. She was keeping a head position also. That was very difficult, and then I had to discuss with the whole entrance team. They will be there, the entrance commissioner office people, and then they checked whether she had these marks. She has very good marks in the board exams. So they checked whether she wrote the exam with that assistance or not. She didn't. Actually, she was a very smart girl, answering everything and behaving very with a lot of drive, and we can't say no to that. So I finally wrote S. What the commissioner office and the board finally decided, I don't know. That it's all changing, no? Because with the Disability Act and all, it has to be on to their side. We have to be on to their side. We can't deny that you are incapable just because we are normally or whatever ability we have. They are differently abled, so they can do a lot of things which we may not be able to do. So we can't say no. That is my policy, but there were a lot of other doctors who were saying no also. But in this case, because it's an ophthalmology disability, I have a better say. Thank you.